This is presentation chest imaging 5 prepared by Prof. Sharaf and revised by Prof. Yusra Sabri. It is for the mediastinum, and we start with mediastinal cysts. Could be congenital cysts, bronchogenic, enteric, neuroenteric. Could be cystic tumors like lymphangioma, teratoma, teratodermoid, necrotic lymph nodes. Could be others like pericardial cyst, thymic cyst, pseudocyst of the pancreas extending into the chest, meningocele, chronic abscess, old hematoma, cystic goiter, and dilated fluid-filled esophagus. Now here is an example of the bronchogenic cyst, mostly near to the trachea, in the middle or the posterior mediastinum. And of course, there are something identical to this bronchogenic cyst is the esophageal duplication cyst. The only difference it may be that the wall may be thicker and in more intimate contact with the esophagus, more related to the esophagus than to the trachea. Although of course in large cysts you cannot differentiate. In neuroenteric cysts, there should be vertebral anomalies, for example like scoliosis. So these are simple cysts near to the trachea, near to the mid or posterior mediastinum. Could be bronchogenic, could be duplication, could be neuroenteric. The more posterior is the neuroenteric, the more related to the esophagus is the duplication, the more related to the bronchus is a bronchogenic cyst. The one related to the heart will be, of course, pericardial cyst. The one anterior to the region of the thymus will be a thymic cyst. The one in the cardiophrenic angle is again pericardial cyst. While posteriorly, if there is protrusion of the CSF in a closed space aligned with the vertebral column, this will maybe a lateral thoracic meningocele with intraspinal connection. One of the anterior cystic tumors is the mature cystic teratoma. It is a benign, smooth cystic containing fat, and if malignant, is thick with enhancing capsule. It is in malignancy, you can see a thick enhancing capsule. The second thing which can occur is the lymphangioma or the hygroma, which is sometimes called cystic hygroma, usually in 1 to 2 years of age, uni or multilocular. It could be capillary, could be cavernous, could be cystic, and usually encasing mediastinal structures. May extend, of course, to the neck, or it starts in the neck and extends in the chest. Here we have a right superior mediastinal cyst near to the carina. So we want a differential. Could be bronchogenic, could be duplication, could be neuroenteric. If the cyst is intraparenchymal, it usually presents clinically with recurrent infection. Again, these are examples of the cyst related to the middle and posterior mediastinum. If related to the trachea, it is a bronchogenic cyst. If related to the vertebra, it is a neuroenteric. If related to the esophagus, it is a duplication cyst. Posteriorly, the most common is the neurogenic tumors. Is the most common esophageal carcinoma, paraspinal abscess, vascular like aortic aneurysm, congenital, which could be extending bronchogenic cyst or enteric cyst, trauma, which could be hematoma or aneurysm, deposits, hernias, and finally extramedullary hemopiesis. This is the definition of the posterior mediastinal masses. Here is a posterior mediastinal mass. It is seen in the CH-5 as a paratracheal opacity of well-defined outer margin. So if we say that there is an opacity with well-defined outer margin, if wavy and bossy, this would be lymph nodes. If smooth and continuous, this may be a posterior mediastinal benign mass. And here the ganglioneuroma is the most benign aspect, benign in the spectrum, and it is seen as elongated, elliptical, triangular shaped, sometimes with calcifications. Of course, in the CT there is some indentation and pressure change on the vertebra related, and there is enhancing epidural margin bulging into the spinal canal. A well-defined posterior mediastinal mass seen again in the chest PA as a well-defined paravertebral bulge with intact spine, so we can exclude Pott's disease. The differential of a well-defined posterior mediastinal mass could be aortic aneurysm if it is aortic, but here it is not aortic. It could be it's mostly neuroenteric ganglioneuroma or neurofibroma or enteric duplication. These are the most common well-defined posterior mediastinal mass: aortic aneurysm, neuroenteric tumors, ganglioneuroma, neurofibroma, and enteric duplication. As we said, the neurogenic tumors in the posterior mediastinum are the most common, and the ganglioneuroma is the most benign of them. Here is a tumor that has a texture of a mass and not a cyst, with widening of the related intervertebral foramen, and it is seen as the left paratracheal mediastinal widening at the apex of left lung, seen in the CT as soft tissue mass with enhancing margin. This is the most common intrathoracic neurogenic tumor. Or we can say this is one of the most common intrathoracic neurogenic tumor. It shows peripheral enhancement and it is not a cyst. The other one was a neuroenteric cyst This one is a neurogenic tumor mass. We have the esophagus itself seen as dilated esophagus expanded with a mass, and that is the most common appearance of characteristic of leiomyoma. So we can say that this is a leiomyoma, and the contrast is seen in surrounding, except in some parts. Squamous cell carcinoma would produce more irregularity and less dilatation, and a polyp is usually smaller than that. This appearance is usually of a leiomyoma. Here there is a posterior mediastinal mass, and this posterior mediastinal mass is seen encasing the aorta along with enlarged retroperitoneal lymph nodes. Testicular carcinoma can produce posterior mediastinal mass. Second is lymphoma, so metastasis number 1, lymphoma number 2, enteric cyst, if it is a cyst, aortic aneurysm, esophageal tumor, but not leiomyoma, of course, and by CT the underlined are excluded. We can exclude here a cyst, we can exclude an aortic aneurysm, we can exclude esophageal tumor, so we are left with a lymphoma encasing vessel or metastatic lymph nodes. Posterior mediastinal lymph nodes, if proved that these are lymph nodes, it's always neoplastic. If proved to be lymph nodes, it is always neoplastic. Now this is a mass which is anterior mediastinal mass, is either lymphoma, thymoma, germ cell tumor. Hodgkin lymphoma is 2/3 half thoracic involvement at presentation, and the nodular sclerosing type is the commonest. Now we can see that the anterior mediastinum is full of a mass which is heterogeneous, mainly low density and encasing vessels. Masses encasing vessels are usually lymphoma. Masses encasing vessels seen as wide superior mediastinum, large anterior mediastinal mass seen in the lateral film, and in the CT it is seen extending extrathoracic as well, and of course there is definite encasement of the large vessels of the at the arch of the aorta. These are the lymphoma, characteristic of lymphoma. But the most common primary anterior mediastinal tumor as a primary is a thymoma, and then lymphoma comes second, germ cell tumors come third, and the carcinoma is last. So the first is thymoma, then lymphoma, then germ cell tumor. Teratoma is one of the common primary anterior mediastinal neoplasm. It forms 18%, appears as rounded anterior mediastinal mass with mixed attenuation. You can find water, you can find fat, you can find calcification or teeth. 95% is anterior, 5% is posterior. 3 subtypes we have: the mature one with cyst, the immature with fetal elements, and the malignant teratoma. So teratoma is one of the anterior mediastinal tumors which forms 18% of the whole spectrum. First is thymoma, second is lymphoma, third is the germ cell tumor, and finally is carcinoma. Anterior mediastinal mass, again the 40s, we know. Germ cell tumors include not only teratoma with its spectrum as the benign or the immature, but also you can include seminoma or choriocarcinoma deposits. So we have the thyroid, thymoma, lymphoma, teratoma, and as we said, teratoma forms 18%, and we have three subtypes: the mature teratomas, the immature teratomas with fetal elements, and the malignant teratomas. Now for this, amongst the germ cell tumors you should know is the seminoma or choriocarcinoma deposits. Seminoma and choriocarcinoma deposits are considered amongst the teratomas we know: the mature, the immature, and the malignant. Besides the known lymphomas, thymoma, and thyroid, if there is upper limit, it's never is not thyroid. If there is, if it is to a side, it is not a thymoma. If it is encasing vessels, it is a lymphoma. If it is displacing and extending out, it may be teratoma. And in this respect, we have the mature, immature, and malignant, as well as seminoma or choriocarcinoma deposits. Here we can find that there is a mass, and the mass is seen displacing the trachea anteriorly, and it is seen continuous to the, its soft tissue is seen continuous to the neck, and the trachea is mildly shifted to the left. Here the trachea is shifted to the left. Here it is encircling the trachea mainly on the right side, and here it is extending posteriorly, displacing the trachea anterior and to the left. The most common primary anterior mediastinal tumors are the thymomas, as we said, lymphomas, number 2, germ cell tumors, and the carcinomas. Still, there is a place for the sinus, for the thyroid anterior mediastinal mass, which could be paratracheal or retrotracheal, extending into the neck, deviating the trachea with cystic changes, calcification. The differential diagnosis here is a thyroid or leiomyoma. This one here, we have soft tissue surrounding the aorta of the same density as fat, and this is called lipomatosis and widening of the mediastinum, but this could be due to a hematoma or aortic injury according to the history. We should exclude history of hematoma or history of aortic injury to describe this as fat and only fat. In case it is fat and only fat, it is lipomatosis. Thank you.